Okay, welcome everybody. This is, if you can believe it, this is 1 year since we started doing the Radical Philosophy Hour, which is wonderful. And we are just so excited to have the Compost Collaborative here with us, proving, I think, I hope, I believe, that the work of the Radical Philosophy Association is wonderfully interdisciplinary, that there's a lot of crossover and conversation to be had. So we're just very excited to be able to feature the Compost Collaborative today. Let me just announce while we start off today's meeting that for May, we'll be hearing two really interesting talks. One will come from Ian Reynolds, and the title of that is The Formative Role of the Party in Lukács's Philosophy of Practice. He'll be talking about basically the role of the party in contemporary politics. Anita Cherry will be our other presenter. Anita is a political theorist, somatic educator, and writer based in Portland, Oregon. And I think she's going to be talking about similarly something to do with Lukács. It's actually, here I have the title, The Flexible Language of Anti-Ideology, Claire Fontaine and the Practice of Defunctionalizing Knowledge. So they sound like really interesting and exciting talks. I hope everybody makes sure to tune in for those. So today, as I mentioned, we have with us the Compost Collaborative, just a really exciting project and idea. It's a new materialist and critical post-human rhizome of feminist, queer, nursing joy and terror. The Compost Collaborative's collective work allows them to wrestle some of the wicked and enduring problems of our dystopian present. As friends, collaborators, and scholars, they are deeply connected by a shared commitment to a radical path for the future of nursing, a commitment that began before the pandemic, but which is all too relevant in these COVID times. They call themselves the Compost Collective, or Collaborative, sorry, I said that again, a nod to feminist multi-species ecologist Donna Haraway, who captivated their collective imagination and informs their approaches to eroding boundaries of all kinds in nursing and in life. They are scholastically and tentacularly connected in their collaborative work as nurse-compost-scholars. So this talk will be based on their collaborative work, and I'm going to let them introduce themselves individually, but they want to say the collaborative is fungible and their ideas are collective, part of a social process influenced by people, animals, environments, and ideas far and wide. As they work and think and do, they center their deep love, respect, and solidarity for the nurses and others who are actively engaged in the dangerous daily work of caring for folks with COVID-19. With that, I turn it over to the Compost Collaborative to introduce themselves individually.
Thank you so much, Brandon. Good afternoon and welcome to our presentation. We have titled Death and Dying in COVID Times, the Necropolitics of Ecmo. The ideas we discuss today represent a work in progress, and we're grateful for the opportunity to talk and think together and to get feedback in this virtual space. Indeed, it's our pleasure to participate in the Radical Philosophy Hour and join with the RPA community again after virtually meeting some of you at the conference this past November, where some of us here presented in the conference session on immigration, healthcare, and radical imagination. We'd like to start with brief introductions, and then Eva will begin our talk by sharing our positionality statement. My name is Jane Hopkins Walsh. I use she, her pronouns. I'm a PhD nursing candidate at Boston College and a pediatric nurse practitioner at Boston Children's Hospital. My clinical area of expertise is pediatric and young adult care with immigrant and asylum-seeking families in the US and primary care with families living in rural Honduras. Brandon?
Hi all, thank you for the invitation to be here. My name is Brandon Brown. I'm a clinical professor, assistant professor at the University of Vermont in Burlington, Vermont. I use he, him pronouns, and my clinical sort of specialty is surgical nursing, trauma nursing, and post-surgical nursing. I would like to turn it over to my colleague Jamie for his introduction.
Thanks, Brandon. Hi, I'm Jamie. I use he, him pronouns, and I am a researcher and nurse teacher in a university in Berlin. And I just finished my PhD in Edinburgh, and my clinical background is organ donation, transplantation, and intensive care. Now I'll hand over to my colleague, Jess.
Hi, I'm Jess Dillard-Wright. I'm an assistant professor at UMass Amherst. I'm also a nurse and a midwife. My clinical background is primarily centered in trauma, shock trauma, critical care, and I'm delighted to be here today. I now will pass it off to Eva.
Thank you. Hi, my name is Eva Willis. My pronouns are she and her, and I research and teach in nursing, and I work also at the university in Berlin, the Charite University. I've experience as a nurse in the United Kingdom and in Germany in residential care, intensive care nursing, nephrology, and dialysis. And now we'll address our positionality. We believe this is especially important because the people and the places that we come from are not innocent. And not only do we speak about our privileges, but we also speak about the limitations of our position and our perspective. When you look at us, you can see that we're all white and we're benefiting from speaking on the oppression of nurses, while we are living a relatively comfortable life in higher education contexts. When you look at us, you see that we are embodying and living colonial realities that are very much alive with us. Some of us immigrated and others were forced to relocate. Some of our ancestors fought in the Second World War, mind you, on the bad side. Should we then call ourselves colonizers and genociders? Some of us have histories that might mingle with the history of the sons and daughters of the American Revolution and the Confederacy. We don't hold particular faiths, consider us as atheists or agnostic, but we understand that religious and secular beliefs are still grown into us. We are all able-bodied. We hold nationalities that enable us to travel globally with few restrictions, moving with the benefit of the doubt, for now at least, because there's also a war going on in Europe. Jamie and I live in Berlin, and the distance from Berlin to Kiev is similar to the distance from LA to Santa Fe or from Philadelphia to Georgia. We are American, British, and German, and all, of course, speak English. We are all educational climbers and consider ourselves middle class. We are embedded in higher education, and we're all nurses, with some of us practicing. We are researching and passionate about the philosophies in nursing that we work with. We work with the theories of new materialism and posthumanism. As academics, we understand ourselves more as a collective than individuals. Rather than survival of the fittest, we believe in survival of the most collaborative. But we also have to acknowledge that we never had to fight for survival, and we have a life of relative abundance. We are collective rather than individual because we understand that embeddedness is vital for change. And now I would like to give it over to Jane, who will address today's objectives.
Thank you, Eva. To give you all an overview of where we're headed in the time we have together, we'd like to start with some descriptions of the philosophies that inspire our thinking, including Mbembe's necropolitics, and ideas drawn from philosophical areas of critical posthumanism and new materialism. We will briefly define Ecmo, the biomedical technology that's central to our argument today, and then connect the discussion to the necropolitical economies surrounding life and death under global late-stage capitalism by looking at situated contexts of living and dying in the US, UK, and the EU. We'll end with questions and thoughts on how to imagine a new materialist future by way of a call to affirmative ethics. To begin, we ground our discussion in the time period that nurses in the pandemic labeled the COVIDicene, an era marked by pervasive death, now over 6 million plus deaths from COVID-19 worldwide. A time period also marked by hypervisible, persistent, pervasive inequality. I turn the discussion now over to Jess, who will contextualize the COVIDicene as it relates to the topic today.
Thanks, Jane. The realities forged and exacerbated by the COVID-19 pandemic have occasioned broader engagement with an otherwise esoteric means of life support, extracorporeal membranous oxygenation, a mouthful, also known as ECMO. This heroic measure has entered the popular discourse during the COVID-19 pandemic. And today we want to take up the question of ECMO and think about the necropolitical economies that spring out of the rationing of this kind of nursing care. And we thought it was advisable to take a moment here to kind of offer a caution. We want to make space for the fact that as nurses, our daily work has frequently meant close contact with critical, emergency, and end-of-life care. In a word, proximity to death. We wanted to offer this to temper what might seem casual or familiar. Frankly, it was and is a part of our daily work life rather than something remote or abstract. And that's been true for our entire careers. We do think that there's appetite for this conversation right now because of the ways in which life and death and everything in between have been front and center for all of us in these pandemic times. For some, more so than others, neither remote nor abstract. We also want to make space and attend to the fact that folks who may be watching today have had some closer experience with this in recent times than they've ever had to before. So again, to start, we'll define our terms, including what Ecmo means and how it functions. We go on to consider necropolitics, contrasting the necropolitical economies of Ecmo across 3 distinct nursing milieux. This analytics of necropolitics kind of leads us to a critique of the transhuman impulse to attenuate death in healthcare. We'll conclude with a call to speculative and affirmative ethics, activating a radical imagination for what else is possible for care, a reparatory intervention for the white, cis-heteronormative, ableist, colonial, patriarchal structures that limit health, well-being, liberation. I now turn this over to my comrade Jamie, who will launch our discussion of necropolitics.
Thanks, Jess. So necropolitics, originally used by Black political theorist Akhil Mbembe, is a term which has been growing in use over the past few years. Necropolitics discusses the contemporary state-sponsored death that cannot necessarily be explained by theories of biopower and biopolitics. Necropolitics is a diffraction of the Foucauldian concept of biopower, which can be understood as power over life and the body, or as Lemon-Vatter call it, the government of life. Necropolitical thought seeks to diffract historical and contemporary, cis, hetero, white, colonial, social and political productions of power over life, and make perceptible the omissions, sacrifice, suicide, and martyrdom, which are pervasive in producing the advanced capitalist and proto-fascist pseudo-realities of white techno-medical supremacy. To quote Mbembe, sovereignty resides to a large degree in the power and capacity to dictate who may live and who must die. Hence, to kill or allow to live constitutes the limits of sovereignty, its fundamental attributes. To exercise sovereignty is to exercise control over mortality and to define life as the deployment and manifestation of power. So from this, we can think that Foucauldian biopower as a domain of life over which power has taken control. Or perhaps in a more Spinozan way, what productive powers, potestia, creates life and what restrictive powers, potestas, destroy the possibilities for life. As Braidotti says, we are in this together, but we are not one and the same. The category of human that has come to represent the dominant minority does not represent the quantitative majority of humanity. At the moment, cognitive capitalism has intensified humanity's reliance on high-tech economies that caused the problems in the first place. As we mentioned earlier, our entry point into this subject is not neutral. We are practicing nurses in advanced capitalist economies of the global north. Therefore, our perceptions of life and the power we have over it are deeply entangled in the bio, techno, algorithmic models of care. But thinking with necropolitics, under what practical conditions are we allowed to die or to live? Who is the subject of this right? Who has the right to make these decisions, and on what or whose knowledge? What does the implementation of such rights tell us about the person who is allowed to live or die? Is it even our choice? Whose choice is it? Also, what does this tell us about the relationship between nurse, doctor, patient, bodies, life? What and who can control what and who matter? Is the notion of biopower sufficient to account for the ways in which the capitalist techno-scientific complex, under the guise of evidence-based medicine, person-centered care, and patient safety, have come to dominate healthcare? We know evidence-based medicine is predicated on whiteness by exclusionary recruitment to randomized control trials. Patient safety makes us think of who must we keep safe from what? Are we keeping patients safe from us? And person-centered care is based on rational agents making decisions for themselves, but that's modeled on a neoliberal consumer. But what if we were never considered a person to start with? How is your sovereignty and agency produced in this situation? Or is it not? These are the necropolitics of contemporary healthcare. Now I'll hand over to Eva to discuss the transhumanism in a little bit more detail.
Thank you, Jamie. We work with new materialist philosophies in order to question the assumption that the human is at the center of the universe and to address the symbiotic agency of non-human entities. Both transhumanism and posthumanism are defined as philosophies of new materialism. We differentiate the two in order to address the potential conceptual confusion, or as Ferrando states, to detect the distinct theoretical ontologies that are proposed by these concepts. And as we're now addressing transhumanism, I also want to note that we're not experts in the field. And to position ourselves, we contrast transhumanism from the perspective of critical feminist posthumanism. Transhumanism, just as posthumanism, builds on humanism. Humanism was established through the tradition of enlightenment. Humanism perceived the self as an individual, rational subject. The human is believed to hold hierarchical superiority over the other forms of being, to be at the central importance. Due to the implications on how we order the world with an anthropocentric philosophy, humanism has been heavily critiqued. Following Ranish and Sorgner, transhumanism, according to its self-understanding, is a contemporary renewal of humanism. It embraces and eventually amplifies central aspects of humanistic thought, such as beliefs in reason, individualism, science, progress, as well as self-perfection. Because of my German positionality, I find it crucial to point out that Ranish and Sorgner also remind us that the term transhumanism was coined by Andrew Huxley in 1957, and amongst other positions, he was the president of the British Eugenics Society. Of course, transhumanism has changed since then, towards the transgression of humans' biological boundaries by means of technology. Transhumanism seeks to make humans better, faster, and stronger. The human in transhumanism is reconfigured with technology. That means that transhumanism remains anthropocentric. We believe that this presumes a transcendental design where the human remains the locus of rationality, no matter how networked they become, and salvation of humans will come through human intervention and innovation. And now to contextualize this a bit more, to Jane, who will address posthumanism and why we, when we think about living and dying, think with a new materialist approach.
Thanks, Eva. Now a few words on critical posthumanism. Why do we nurses need a new material, critical posthuman approach to living and dying? Well, we think this is a question not just for nurses, but for the folks whom they care for, and that's all people who will need currently nursing care, most all people. Academically, we also see this as relevant for artists, thinkers, activists, philosophers, and scholars who are interested in broad intersectional issues of human and non-human health, climate issues, planetary and social justice. First, we see critical posthumanism as moving beyond and between the limitations of humanism, as Eva just described. The binary approaches of humanism that ground our discipline of nursing maintain separations and silos between theories, disconnecting care practices, constraining nursing knowledge development, and limiting possibilities by assuming and perpetuating the fundamental preconditions tied to Western empiricism. Humanism as the reigning philosophy of science that powers the Western biomedical machinery, the philosophical and the material views and beliefs that reinscribe Christian colonial priorities on the bodies of the people we accompany in care, and on nurses as well. We see more radical possibility in critical posthumanism, new materialism, uniting theory and praxis to welcome the concept of monoism through obliteration of the dualistic binaries of humanism, with presumed objectivity and false separation of nature, culture, mind, body, and human and non-human and more than human. In the spirit of philosophical and historical critical inquiry, we advanced what we understand as an urgent critique of current nursing thought, predicated on the perils of humanism. Perils like white supremacy, white empiricism, patriarchy, capitalism, colonialism, norms and laws demanding adherence to cis heteronormativity, planetary destruction through relentless extraction and capitalism. The gravity of our critique lies in our deep and earnest concern that in failing to adequately reckon with the troubling normative narratives that characterize our professional discipline, our political milieu, and the planetary environment, we risk continually perpetuating the inequities that plague us in both healthcare and society more broadly. As Brandon introduced us, we are the Compost Collaborative, and we use that term as a nod to feminist multi-species ecologist Donna Haraway, who captivated our collective imagination. Together, our critical posthuman thinking and writing practices are messy mashups, tentacular and rhizomatic, with inspirations from Black feminist and Indigenous writers and thinkers, dancers, musicians, artists, and poets, including, to name a few, Bell Hooks, Kim Tallbear, Fanon, Freire, Deleuze and Guattari, Foucault, Puig de la Bella Casa, Sylvia Wynter, Dipesh Chakrabarti, and Angela Davis. We draw upon Deleuze and Guattari's rhizomatic thinking, Kaba's abolitionist organizing, Haraway's sympoiesis, and Braidotti's posthuman convergence. We agree to stay with the trouble and not presume that there's a single approach or an easy fix or solution. We invite critique and discourse. We see this work together as messy and nonlinear, a drift that holds bold possibilities for reimagining approaches to wicked problems, including actions based in rhizomatic thought, with visions of just episteme, liberatory pedagogy, and more affirmative nursing care for people who are dying and living on a dying planet. Now Brandon will describe and discuss Ecmo.
Thank you, Jane. So we're going to be moving into the Ecmo of our presentation, and it's necropolitical economy. And so to begin with that, I would like to just kind of describe to you what Ecmo is. And well, the best analogy that we can imagine is that Ecmo can be thought of as a proxy placenta, giving and granting a body life. Just as a placenta delivers blood and oxygen to a fetus to bring about life, an Ecmo machine is a highly invasive transhuman technological apparatus that is used in a similar manner. However, it does not bring about life, but sustains it. You see, Ecmo is used in situations in which the heart and or the lungs of a person are so damaged, they can no longer function and sustain life. A machine is transformed and becomes an artificial heart and lungs, a machine that beats and breathes, removing blood and oxygenating it outside the body and pumping it back in. Well, the person is often rendered unconscious, giving rise to the ultimate cyborgification of the human, with a nod to Haraway, a heroic and final assemblage in an attempt to sustain life by providing umbilical nourishment, a practice known as the Hail Mary of efforts. As you feast your eyes upon the image of this slide, giving you a glimpse of what Ecmo looks like, I ask you to envision what it would be like to be an observer in this context, visualizing the lines going in and out of the patient, removing blood and oxygenating it, returning it to the body, hearing the soft humming of the Ecmo machine, the breathing and beating and whirling of the artificial heart and lungs, the technological apparatus of life amongst the backdrop of beeping monitors, beep, beep, beep. Transhumanism at its finest, maybe survival of the fittest perhaps, but we also see threads that link Giorgio Agamben's concept of bare life, where the person has been relegated to the status of a body, but is still seemingly part of the capital apparatus, causing us to consider, is this one of the myriad of ways death manifests and is managed under capitalism? You see, managing the Ecmo machine requires a substantial amount of resources that are delivered through the labor of nurses. Each patient on an Ecmo machine requires a single nurse caring for them, often more than one. It requires countless technicians and physicians, all of which are in short supply. And at least in the US, it might even require the decision of an insurance company. The cost of maintaining a person on an Ecmo machine is around $5,000 a day in the United States. Many patients can be on Ecmo for months on end. Within the past 2 years, there have been moves to place patients with COVID-19 on Ecmo. Despite the general outcomes of Ecmo patients, adult Ecmo patients not being as high as they are for newborn and pediatric patients. Slightly under half of adult COVID patients who are on an Ecmo machine will survive, according to a recent study in Lancet. However, at the same time, almost half of COVID-19 patients on Ecmo will survive, so not all the outcomes are bad. We hear many survival stories of folks who made it off Ecmo and honor their lives, their illness, and their struggle. But in the same vein, in practice, there are a high risk of complications. And we have often seen patients remain on Ecmo for extended periods of time, despite a loss of medical hope and expected recovery. While we honor survivors, we also want to honor a dignified death, leaving us with a lot of ethical and necropolitical questions. So we wonder if at times, if Ecmo is used as the final act of generating capital for the neoliberal medical system, dehumanizing the human body to bodily waste for extraction, a question that we ask you to ponder as we move through our presentation. We will now move forward and discuss the necropolitical economy of Ecmo in various geopolitical contexts. Next slide, please. Eva, thank you. One more, please. I ask that you turn your eyes to the image on this slide displaying the availability of Ecmo treatment centers around the world. This is a live map based on the latest status of Ecmo centers around the globe. The green pins indicate places where Ecmo is available to patients. The yellow pins indicate limited capacity based on available data, and the red pins indicate major medical centers where Ecmo machines are not available. And finally, the gray pins represent no available data at all. Looking at the map, I ask you to consider the geopolitical spaces in which there are no Ecmo centers available, no pins at all. As I have previously mentioned, Ecmo does offer many patients and families hope for survival, but in these desperate locations, we see the turn of neoliberal healthcare and its necropolitical economy hard at work. The barren lands when Ecmo is not even an option to begin with. A recent study in the American Journal of Respiratory and Critical Care Medicine found that 90% of COVID-19 patients who need Ecmo and do not have access to it will die. We see an entangled thread in this map to Mbembe's concept of zones, or what one might call death zones, where certain populations are closer to death, in which Mbembe calls the living dead, those who do not have sovereignty over their own body, the sovereignty which has not been granted to them via the mechanisms of capitalism, the medical insurance industry and industrial complex, and the healthcare apparatus and workforce. We will now go on to discuss the necropolitical economy in the context of Germany, the UK, and the US. I will now turn the floor over to my colleague, Eva, who will describe to us the specifics of Ecmo in Germany.
Thank you, Brandon. Germany has 83 million people living in it and has a semi-private and semi-public healthcare system. Everyone has guaranteed health insurance. Insurance is tiered depending on your income, and it's collected automatically from it. If one's spouse does not have an income, the working person automatically covers the cost for the spouse and children as well. So it's all included from one person. People who are unemployed, in education, or retired have guaranteed healthcare cover. Although people insured in Germany can pick between different health insurances, the provided services only vary very slightly. Coverage is extensive and not very restricted. Hospitals get paid by pre-calculated procedure costs by health insurances. In a recent study, Friedrichsen et al. Looked at all 4,279 Ecmo treatments in German hospitals between January 2020 and September 2021 during the COVID pandemic. They found that 270 facilities did Ecmo treatment, with 60% of them offering Ecmo treatment having only one treatment per year. Let us highlight that 270 facilities in a country with 83 million people compared to Ecmo centers, compared to 7 Ecmo centers in the UK with a population of 67 million. But back to the study that looked at Ecmo treatments in Germany. The in-hospital mortality rate of Ecmo treatment is between 66 and 72% during COVID, with the highest mortality rate of 84% in the months of September 2020 and September 2021, and a 92% mortality rate for patients above 80 years old. As international guidelines are not as binding to doctors in Germany as they might be in other healthcare contexts, this might lead to more patients being connected to ECMO than in other countries. And this then leads to high frustration rates in staffing, nursing staffing, as they might feel that treatment is not always in the interest of the quality of life of the patient, but rather favoring the optimization of profit margins. And now I give the word to Jamie, who will address the context of ECMO treatment in the UK.
Thanks, Eva. So, like Eva said, the UK has around 67 million people, and the health service is a national health service, a socialised health system that's free at the point of use for all. It's funded through taxes called national insurance, and these taxes are only paid when you earn more than £14,000 a year, and it's collected directly from your salary. If you don't work, then no payment is required, and the same level of service and care is provided for everybody. The NHS has 7 ECMO providers in the UK, 6 in England, 1 in Scotland, and none in Northern Ireland. Consider the geopolitics of that already from recent history. This is distributed geographically and commissioned at a national level. The clinical eligibility criteria is based on predefined population needs, which are defined again at a national level. So that means that ECMO will be provided for people with severe respiratory failure, and it's estimated around 200 to 300 people have ECMO in the UK or are eligible for ECMO in the UK each year. And the morbidity and mortality hovers between 60 and 70%. All this is based on the CESAR trial, which is an interesting name in itself, right? Transhumanists, but showed that transferring adult patients with potentially reversible severe respiratory failure to a centre with an ECMO-based treatment significantly improved survival without severe disability at 6 months. So this sounds great, right? A cost-effective treatment for those who will benefit from it most. But as you might suspect, we have some concerns with this model. First, admission to the ICU in the UK is rationed. ECMO is delivered in the ICU. The UK has significantly fewer ICU beds than other comparable health systems because, much like the thinking with ECMO, the system is based on admitting those who will get the most benefit from ICU. But who makes that decision and how? And what about those who will have some benefit, but in the context of not having the most benefit? And how and who decides what benefit is? Do we measure benefit in life, or do we measure benefit in a good affirmative death? Second, admission to the ICU in the UK is based on value judgments by clinicians. We value these judgments because we make them ourselves and we know how difficult they can be. Asking a vulnerable and critically unwell patient or their family to undergo a treatment like ECMO or ventilation with little overriding benefit can be tortuous for the patient, the family, and the staff looking after them. However, who and how do we make these decisions? What knowledge is it based on? Well, these decisions based on pattern recognition and previous experience, but that's also deeply entangled in our own prejudices, of which we cannot escape, only reflect and work against. We have studies that have shown that there are big differences who gets admitted to ICU based on dimensions of diversity, such as age, race, and socioeconomic class. So all that glitters is not always gold. And with that, I'll hand over to Jess.
Thanks, Jamie. The terrain of healthcare in the United States is fraught, and it's characterized by uneven access to care, a reality that changes state to state and even community by community. For those of us who've ever changed jobs in the United States, it changes from insurance company to insurance company and plan to plan within insurers. This makes it really difficult to summarize what our healthcare system and our payer structure is like. But as of 2020, the US population was around 330 million, and we have about 100,000 ICU beds in the US. Based on data kept by the Extracorporeal Life Support Organization, ELSO, there are 357 ECMO centers. Now, that's not the number of beds, it's the number of places that can do ECMO in the United States. And that's out of a current world total of 763 ECMO centers. Again, centers rather than individual ECMO units. So approximately, according to ELSO, approximately 48% of those adults who receive ECMO in North America go on to hospital discharge, right? However, a recent retrospective analysis by Kahn et al. Of ECMO outcomes for COVID patients at one New York City center revealed a 96% survival rate. But let's take taking a closer look at their decision algorithm for whether or not a case should be considered in their retrospective analyses, right? They looked at 77 cases. Only 27 of those cases ended up being part of their study. So that left 50 records that they looked at, but they determined wouldn't be a good fit for their study. Some of those folks were determined to be too well for ECMO. They would likely survive without being put on ECMO in the first place, or, and this was the vast majority, too sick for ECMO, right? And there was 4 who were unfortunately CPR in progress for whom ECMO would not be realistic. And so this reflects kind of a battlefield triage approach, right? And what I think is really important is something that Jamie is already kind of getting at, teasing out, is that you can't account for the structural barriers that might lead somebody to be too sick in the first place, coming into the hospital, right? So the kind of care that you receive is going to be predicated on your pre-existing health conditions, and these pre-existing health conditions are not something in the United States that are well accounted for in a system that is linked up with your employer and your ability to pay. So, and the care that you might receive if you need ECMO, it's quite expensive, right? One system, I know Brandon threw out the number $5,000. Another study suggests that ECMO care related care costs range between $4,500 and $11,000 per day, an average, and then the median was more like $4,000 to $13,000. So these costs are widely variable and are likely fungible depending on how sick a person is in their care. So we know from Brandon's discussion of ECMO that it's a heroic measure, a last-ditch effort to bring an adult back from the brink, a kind of nightmarish simulacrum of umbilical nourishment spanning the space between life and death. And it's incredibly resource-intensive, both in terms of supply and personnel, particularly when paired with the complement of technologies one might expect to accompany ECMO in a critical care setting. And periodically in the United States, the specter of healthcare rationing by, quote, death panels appears, a bogeyman scaring the unsuspecting into appropriately consumerist submission, as we saw in the discourse against the now entrenched Affordable Care Act. Thanks, Obama. Rarely, it seems, do we talk about the rationing forced by late-stage capitalist influences, where healthcare in the U.S. is decidedly commodified, available to those who can pay, right? So we're abdicating triage here to market forces. In neoliberal contexts of healthcare, we talk sometimes about easily quantified and counted things. One of the things that defies easy categorization is those who are missing from care altogether. This is a topic Jane and I have written about elsewhere, but we know that folks are missing. A recent Kaiser Family Foundation study showed that around half of all adults, half of us, reported skipping or delaying care in the past year due to cost. And this proportion increases for folks who are uninsured, for folks who earn low salaries, for folks who are Black or Hispanic. And we know that in pandemic times, in spite of the sort of like common sense view of this, the proportion of people who are uninsured because they become unemployed increased significantly. If the necropolitics of the UK resides in saving money, and in Germany in the profitability of attenuating death just a little bit longer to bill more, the necropolitics of the US context begins with the fragmented, inequitable, workplace-bound apparatus that pays, or doesn't, for healthcare. Our state has determined that healthcare, generally, doesn't pay. We in the US have no single payer, no universally available access to care. What we have come to think of as our safety net for care, Medicaid and Medicare, is typically underfunded, and eligibility and coverage varies substantially state by state, at least for Medicaid. Healthcare in the US is a privilege for those who can afford it, and bankrupts even those who might be otherwise financially solvent. And this is catastrophic events like ECMO and also cancer treatments tend to be the sorts of things that lead to financial insolvency. And I think that this underscores the capture of capitalism, the healthcare industrial complex. Broadly, healthcare outcomes in the US are stratified along socioeconomic lines, yes, but also by race and by gender. This is not just the case in COVID times. We can look at maternal morbidity and mortality rates, which are abysmal in the United States. The highest per capita spender on healthcare in the world, and yet we can't seem to keep people alive in childbirth. And while the numbers are abysmal, the people who are most harmed by these numbers are Black and brown women in the United States. So yes, this applies to high acuity things like ECMO, but also other kinds of care that, under the right circumstances, enhance well-being, foster liberation, prevent the need for things like ECMO in the first place. The necropolitics of ECMO in the US are driven by absence, by replicating the existing inequities that characterize daily survival in the US, the inability to get care in the first place. We are all in this together, Brododi reminds us, but we're not all the same. We know, for example, that Black and Indigenous communities in the US have been hit particularly hard by COVID-19 mortality, and we've yet to see the full breadth of what COVID-19 morbidity might look like, who might endure the most there. Eva, next slide, please. Advance one more. So we'll now talk a little bit about attenuating death for profit. Critical feminist posthuman philosopher Rosa Brododi writes, advanced capitalism is a difference engine that promotes the marketing of pluralistic differences and the commodification of existence, culture, and genetic codes of multiple others for the purpose of consumerism. I think this is instructive for thinking about how capitalism may operate in the necropolitical economy of ECMO. In some contexts like Germany, death is attenuated for that billing purpose. In the US, we effectively ration by ability to pay, abdicating triage to market forces, extracting and caring for those with money to burn, sort of necropolitics by default. Healthcare within this kind of enclosure is definitively an exercise of necropolitical economy, across all settings in all ways, a total institution following Jenkins, Burton, and Holmes on Goffman, and that always mortifies the body and sometimes the wallet too. This discussion, I think, can be overwhelming, right? And so the exercise of thinking about ECMO, because of how totalizing it is, it can be overwhelming. But exercises in thinking about ECMO in particular is a way to take a manageable bite out of this and to think about the capitalist reality of living and dying in COVID times in order that we might think beyond that as well. There are other scales of abstraction, of course, borrowing a turn of phrase from Frank Wilderson III. When we think about the necropolitics of ECMO, nurses are necessary for doing ECMO. Shifting the frame a bit, we could consider a recent American Hospital Association, AHA, cardiopulmonary resuscitation recommendation. Rolling back the received wisdom that you should secure your own oxygen before helping others, the AHA in January 2022 revised its COVID-related CPR guidelines to reflect that healthcare workers should not, I repeat, not delay initiation of CPR to don personal protective equipment. And if we were focusing solely on the person receiving care, as we could maybe understand, that makes sense. After all, it could be a you or a me in need of resuscitation. Time is, of course, of the essence. But even time doesn't really improve the outcomes here. And there's sort of a show must go on mentality in this kind of policy, right? And this policy was ultimately rolled back. But it sort of suggests an inevitability around healthcare workers and their COVID risk. Of course, like everything else about the pandemic, this risk would not be borne out equitably across healthcare disciplines. Nurses frequently being the first and sometimes only responders in code situations, especially in COVID times. And this AHA policy hit at the same time that the Center for Disease Control revised its recommendations for quarantine times for healthcare workers, reducing the duration of quarantine time from 10 days to 5 without regard to symptoms or test results. And this is a worrisome change indeed, right? Necropolitics in a capitalist healthcare scheme inevitably involves workers who are always also possible patients, of course, but are vital to the healthy functioning of the world economy and thus must get back to work, no matter the consequences. Now I give way to my comrade Brandon, who will talk about the redemptive suffering, adjudicating who lives and who dies, and the role of Christian hegemony in these things.
Thanks, Jess. Eva, would you mind just one more, I think, too, please. Oh, perfect. Thank you. As Jess has just described the work of neoliberalism and attenuating death, we also feel that there are other factors and concepts at play that attenuate the dignified death of patients through the work of emotions, Christianity, and redemptive suffering. And I really want to be clear here. I'm talking about folks who are left on ECMO despite the best available evidence that their chance of survival is nil. Beginning with Christianity in the West, historically, nursing science has been birthed from Christian aspects of caring, motherhood, and servitude. As you turn your eyes to the image on the slide of the nurse holding back the angel of death, which is from a 1918 World War I recruitment poster entitled, "Won't You Help?" I ask you to consider the received history of nursing and other healthcare disciplines. The image portends a deep entanglement with Christianity. In this image, the nurse is cast as an angelic entity, holding back the angel of death, ultimately reigning as the sovereign and the endowed agent by God with the privilege of not only protecting who lives and who dies, but also having the ability to select them as well, playing the role of the sovereign and the evangelist, asking others to join. We also see other ways that Christian ideals and emotions attempt to attenuate death through nursing practice and healthcare, especially centering upon the preservation of life at all costs, the gift of God that nursing must somehow protect at all times, even to our own detriment. And even protect this during the futile times of Ecmo treatment to the detriment of personhood and a dignified death. We see this playing out at the image on the left of this slide, illustrating the fear of death of our fellow humans. This image was created by artist Moa Esquerdo and is entitled Get Back to Life, highlighting the heroic measures that society expects healthcare professionals, really bringing to the forefront the aspects of martyrdom, service, and our uncomfortable emotional relationship with death, which is just another talk in and of itself. The image also asks us to contemplate our fear of the unknown, of hell, of what comes afterward. It also asks us to contemplate healthcare providers' fear of failing. One might even suggest it is a veiled attempt at healthcare providers at rendering redemptive suffering. As difficult as it is, we have worked with colleagues who have held deeply religious beliefs on redemptive suffering at the end of life, prolonging needless agony for the redemption of mortal sins. Finally, laid over the top of this image is a much more thought-provoking concept at the end of life, a meme that states, come on, get him. He wants to leave without pain. It is one last fateful attempt at extraction, eclipsing a dignified death. Is this how death is managed under capitalism? It is not just the nurse and physician at the reins, it's insurance companies and the apparatus of the state, all attempting to pull the soul of the patient back to the body in concert of functioning together in the necropolitical economy of Ecmo. Having the sovereign capacity to choose, the capacity to define who matters and who does not, who is disposable and who is not, for the purpose of capital accumulation, homo economicus at the end of life. I would now like to turn it over to my colleague, Jamie and Eva, who will provide us with a few final thoughts.
Thanks, Brandon. So to sum up, Ecmo is a point of convergence that makes us think with life and death. Moreover, the right to live, but also the right to a dignified death. So we have the US, where access to treatments are defined by insurance companies. We have the UK, where state apparatus makes decisions of who is worthy to benefit from treatment. And we have Germany, where we have open access for all to Ecmo, but hospitals who benefit directly from offering Ecmo, financially benefit directly from offering Ecmo. We propose that cognitive capitalist healthcare, with that we mean predictive algorithms in healthcare, evidence-based medicine, patient safety and person-centered care, are important, yet limited and detrimental to the public and healthcare staff. We close this talk by presenting 4 aspects that brings more context to our thesis and our presentation. First, resources in healthcare are limited. Second, we call for a shift from binary thinking of if-then decision-making predicated on the cognitive capitalist machine, making towards a more open, multiple what-if paradigm. Third, we advocate for a collective decision-making process when it comes to treatments. And fourth, we acknowledge that death is not something other and alien from life, but rather a part of life, something that emerges from it. And now over to Eva.
Thank you. Resources are not infinitely abundant. Even if technological procedures are available, sustainability research and research on the climate crisis remind us that all technology is embedded in materiality. Technology is embedded into other material resources and human labor to produce, maintain, and eventually be disposed of as trash somewhere and by someone. Resources are scarce, and that includes nurses. One reason for that is that nursing shortages are influenced by the growing demand of the aging population in the global north. Another reason is that shortages have been exacerbated through the global pandemic. Healthcare staff have been and are dying, especially staff that are Black, Indigenous, and people of color. Growing mistreatment, incivility, and abuse by hospitals, patients, and family towards healthcare staff has driven even more staff away. And lastly, contributing to nurses moving from the bedside, there are current scandals in nursing that signal to healthcare staff that mistakes will not be treated with collective accountability and met with systematic improvements, but rather pushed onto individual nurses. In short, when nurses make mistakes, and beside her being held accountable, we do not ask how the system contributes in setting us up to fail. It gives nurses the impression that extractive capitalism is the most important factor in healthcare by far. Chrisanne Gainey, a licensed practical nurse in Pennsylvania, worked in a care facility where one nurse often looked after between 40 and 60 patients. When an 84-year-old resident fell for the 5th time in 4 days and struck his head, the doctor that Gainey consulted did not transfer the patient to hospital, but asked Gainey to do regular neurochecks, which she forged. The resident died hours later as a result of bleeding in his brain. Gainey pleaded guilty to manslaughter. And most prominently, the case of nurse Daronda Watt at Vanderbilt Medical Center, who made a medical error that resulted in the death of a patient. She was found guilty on 2 charges, reckless homicide and impaired adult abuse. The outcry is so loud that even the International Council of Nurses condoned the criminalization of medical errors in nurses, worrying that healthcare staff will not report them in the future, endangering overall patient safety. We want to repeat, even in countries where access to treatments are abundant, we have to realize that what is not abundant is nursing labor. Even if we have beds, ECMOs, and ventilators, we will not have enough nurses, which means that these treatments cannot be performed. We cannot anymore afford the invisibility of nursing labor. And we also realize that maybe some of the listeners have family members themselves experience such treatments like ECMO or ventilation, and we don't want to dismiss you or your loved one's right to live. At the same time, we're not ignorant to the fact that some people must die and all people will die. As nurses, we don't experience death disconnected from life. However, we do not endorse decisions over life and death being made solely by capitalism and profit. Thinking care only through extractive capitalism is dangerous because there is no value for healthcare providers in death, meaning that wishes for life quality and a dignified death might be neglected, and the agency to decide how and when you want to die is being denied. The reason why we speak about this is because we never leave the patient. We care and we monitor them all the time. And that means that we highlight that treatments are not simply a purchase. They come with tremendous suffering, can be torturous, and can give surviving patients severe PTSD.
So very quickly, just to wrap up, we say that we work with other people like Pre-Dillard-Wright that care cannot be determined in advance. Presently, access to Ecmo and other life-saving treatments is based on categorical systems which are predetermined, and for the system logics that these processes rest upon to properly function. These categories are performing necropolitics. Therefore, to think with care, which cannot be planned in advance, outside of its situated context, alongside algorithmic processes which must be known before and then applied in a situation, it opens up a minefield of contradictions, conflicts, and contextualities. Access to healthcare treatments are reproducing categories of good and bad, new conceptualizations of normality and abnormality, that then act as moral hallmarks of humanness. They perform necropolitics. Ethics need to start from the situatedness of human and algorithmic selves and rely on inquiring into the conditions of emergence instead of a transparent disclosure. As Lloyd might say when discussing Spinoza, affirmative ethics are located by an ongoing effort to make the conditions of our situated bondage perceptible. So as we finish, we wonder, and we'd like to discuss with you, how could the possibilities of life and death in the context of our material situations and resources be handled more affirmatively? How do we manage death from here in the context of late stage capitalism that is afraid of and does not benefit from death? Thank you.
Thank you all for such a fantastic presentation and much appreciated. Eva, would you mind, if you pull it off, then I think, or if you closely share, I think we will be able to see fantastic. Now I think we can see everybody on the live stream. So we only have a few minutes, but I really love to ask questions. And of course, the people on Facebook, if you have questions, please do let us know. I think the first thing I noticed, and I'm interested to hear this teased out some. You started with a couple slides on transhumanism versus post. I mean, you didn't start there, but we ended up with a couple slides on transhumanism versus posthumanism. But I also noticed in your description of Ecmo, you said it kind of realizes a certain transhumanist fantasy or dream. At the same time it does that, I heard that it's perhaps dehumanizing. And of course, your methodological approach is posthumanist. There's a lot of threads there in which those terms are interlaced. And I think it would be really great, I think, to hear you maybe pull out some of those threads. And connected to that, I noticed, rights dignity discourse was a pretty central aspect of your presentation. And of course, I think it's fair to say that those words and that way of thinking, dignity and rights, is very connected to Enlightenment humanism and its emergence. So again, more interlacing of these threads. So I wonder if you could, I don't know, disentangle is the right word, but just sort of follow the threads so that they can kind of be illuminated, if that makes sense. So I'll turn it over to you all to hear what you have to say.
Thank you.
Sure. Thank you for the question. I think that insofar as transhumanism sometimes leans towards this like sort of techno-optimistic enhancement of what it means to be human, right? There's sort of this like myopic optimism sometimes with transhumanism, and I think that that's one of the threads about transhumanism that I think we're a little bit cautious about. But I think at the same time, what we see when we're talking about the assemblages that kind of grow up in the use of Ecmo, we're definitely, I think there's ways that you can understand that as like a sort of cyborgification, right? And that's not just of the person receiving Ecmo, but actually the entire care team is networked together through this kind of assembled praxis that you have to kind of dance through together to get anywhere in critical care. I mean, we could also talk about like critical care environments being sort of a embodiment of that sort of cyborg space. And so, yeah, that's my thoughts on like sort of how the posthumanism and transhumanism kind of collide right there. I do think that the Ecmo is a little verges on the dystopian like line of that techno optimism a lot of the time. And I think one of the themes, and I'm gonna shut up in just like a second. One of the themes that we've talked about a lot as we've been working on this paper is the differences that between how we practice in healthcare environments and what at end of life people who are healthcare workers often choose. The difference is cavernous, right? Between what like the things that I had done in the shock trauma ICU, right, and what I would choose for myself, given the ability to choose. And so I think that there's that like dialectic is one of the things that kind of informs why we think this question is important, why we think it's interesting, and something that's kind of hard to kind of get across. Anyway.
No, it was just, I just wanted to add to what you were saying, Jess, and link it to the emergence of dignity from the humanistic traditions. And a lot of this we don't have words for because death has been a black box, which people do talk about in philosophical ways, but especially in nursing and medical ways, we talk about death in a very predetermined and pre-specified way. So, we're still trying to find the words and produce these things. But what I would say is the dignity that we're talking with is situated from the situation. And I can't describe what dignity would mean for everybody, but I can feel what a non-dignified death looks like, which unfortunately I've experienced a couple of times. And when you're in a situation that's not a dignified death, you'll never forget it, because it's something emerges.
And I think Brandon, oh, go ahead, Brandon, you go ahead.
Yeah, no, and that's what what Jamie is speaking to, is where I kind of, get the dehumanizing angle and sort of had put that in, because as you like bear witness to these, it seems like this is no longer a person here. This person is gone, but instead it's still a body of some sorts. It's still a body that honestly, still a body that serves purpose to the capitalistic sort of like enterprise in a way, but their entire personhood, their humanity is no longer with them. It's almost like, it's almost like the whole thing of like, there are humans, but there are folks who have never been considered human. It's kind of like that flipped in reverse, like this person is human, but is no longer considered human by the system in which it is caught up in.
And I know we're at time, but I think that question, Brandon, that you raised about where do we, weave between humanism, transhumanism, critical posthumanism, I think the critical is something that we keep coming back with, because we even recognize that people who have talked about critical posthumanism still are writing many times from positionalities, that we need to be aware of. And also our early group thinking was very influenced by A Billion Black Anthropocenes by Yousaf, and more recently by Wilderson and Saadia Hartman, to really talk about like the human and who is considered human and who has been considered human in the the philosophy of humanism over time, and really needing to sit with that.
That's really interesting. And I know, Eva, I didn't think you got a chance to speak there. If you would like one, please feel free to do so. I will say, so as you mentioned, Jane, we are at time. If you want, I think we could have time for one more question if people were interested. Would you all be up for that? Okay,
Sure.
Great. Sounds good. All right, so one more question then, and it kind of comes out of what you just said, Jane. And one thing that I noticed throughout was a question of kind of the individualization of the concept of healthcare, and with it alongside that, the concept of health, and also concepts of life and death. So the thing that lives, the thing that dies, the thing that is healthy is a person, and in a singular individual way. But it seemed to me that your methodology calls for, and in some ways you were trying to make visible the ways in which that's a really misguided framework for thinking through life, death, health, and therefore healthcare. And so I know there was a call at the end for collectivizing decision making, but I wonder if we want to think about what health means and is, and what life is, and what death is, in that more collective, but also more materialist frame. So I'm going to turn it over to you all to kind of address that, if you'd like to, in greater detail.
Go for it, Eva.
Yeah, we always say self-determination is not self-sufficiency, yeah? And that's a criticism that we have from a posthuman perspective, so that people in healthcare make their own decisions of what they would like to do, and we fully support this. But with this humanistic healthcare perspective, the implication is that you are independent. And from a posthuman perspective, we want to point towards the fact that, yes, you can make your own decision and you should be encouraged to do so. But at the same time, we have to acknowledge that the reason why you can make your own decisions is because you're depending on many people, and that what you would like to do very much depends also on what other people and places and resources and so on can offer you and can do with you. And that's what we want to point, that the humanistic healthcare system is very much, it's all just about the individual, but doesn't acknowledge the dependencies on everyone else and everything else. Do you want to add to that, Jamie?
No, I was thinking the same thing. Sylvia Winter's self-determination is not self-sufficiency.
And I think that this is a call to conceptualize what. So it's sort of activating a radical imagination around what is necessary for this to move past this entrenched individualist language, right? To call forth a reality, right? Because I think that it is in the U.S. anyway, right? Like we don't. You either have health insurance or you don't, and there's not that much middle ground, and that means that you can get care or you can't, and that's all predicated on this sort of like far like reductive, individualist, privatized narratives that kind of characterize life in under late stage capitalism. We have to do something different. We have to, and that's going to mean dreaming things up that don't exist yet. I have some like ideas, but it's also means like destroying capitalism as we go, right? Like that's not to put too fine a point on it. Um, and maybe the state too. Sorry, bringing the abolition in, guys. Um, in part because uh, I think that's the only way we can actually like activate our collective, like the collective, right? Is through these subaltern pathways right now. But how do we kind of like excavate those and kind of give them the air that they need to flourish?
And you know, to just go off that, Jess, I think we always come back to accompaniment and accompanying people who are most affected by the things that we're talking about, and stepping back and supporting leadership, you know, for communities are very capable of solving their own problems, but oftentimes aren't enabled in the system as it currently exists to do so.
And I would just also add that with the sanitization of death also feeds into this individualization. So death has been sanitized out of our understanding of our agency and self-determination for some good reasons, some reasons which are there to produce profit. So this acceptance of death and like Jane saying, like accompaniment through death doulas, understanding death, planning our death now, or maybe we can't plan our death, but sharing our wishes when we're not able to communicate them, you know. You're not there when you are there when you die, but you're not there to tell someone, no, I don't want that, I do want that. You have to, it's a collective process, and we need to talk about it in advance.
Well, I have to say this has been a really enlightening and interesting conversation, and I do hope that we can continue it, you know, on online for those who engage Facebook. I think Twitter, if not, also check out YouTube where this video will be posted as well. And let's continue a community conversation about sort of doing the work that Jess, I think, so eloquently described for us. Thank you again so much, Compost Collaborative. We've greatly appreciated having you.
Thank you for having us.
Thanks for having us.
Thank you.
Thank you.
Bye-bye.
Bye-bye.